Hi, Lisa White with IVF Manifesting a Miracle, here for another clinical conversation with Dr. Greene. How you doing, Dr. Greene?
How's it going?
Good. Things going well?
Yeah, I think we're both feeling a little bit of chill with this current storm we're dealing with.
Yes, here in Colorado, had a snowstorm, so you're going skiing pretty soon, I think. So
Always, whenever I can.
taking advantage of the winter. So we're continuing our talk, continuing from the last time we chatted about natural cycle frozen embryo transfers. And today we're going to talk a bit more about conventional frozen embryo transfers.
Yeah, and just for clarification, traditionally there had been fresh transfers where, an embryo transfer occurred shortly after the egg retrieval, or frozen transfer. Over the years, we've learned that frozen transfers tend to have higher success rates than fresh transfers. And this is different than what was experienced in the past. And we understand today that the reason that we believe that this has shifted is that when you're doing a fresh transfer, the problem with that was the hormone levels would be so much higher than was physiologically normal that it would create a less than ideal environment to put the embryo into. And so over the years, the technology to freeze embryos got so good that we said, you know what, let's split this up. Let's first do everything we can to optimize the quality of the embryos, and then let's create the optimal environment to putting an embryo back. And that's why it became, fairly routine for many centers to split up the egg retrieval to the embryo transfer. So that sort of differentiates fresh versus frozen.
And frozen has been the way most of the,
I would say in the US, the vast majority of centers have moved towards splitting them because we do see higher implantation rates with frozen embryo transfers than with fresh. But that doesn't mean that a fresh embryo transfer is wrong or that it can't work. It just means that it used to be the standard of care, and now things have evolved more away from that. Does that make sense?
Yeah,
So
we covered a lot on our last talk, was a lot about the natural, and today we want to focus a bit more on the programmed cycles.
Yeah, and the point is when it comes to a frozen embryo transfer, there's two different ways of sort of subcategorizing that. One is where you base a frozen cycle off of a natural cycle, and we talked about that in our previous episode. But today, what I want to talk about is what's more the conventional method, which is to do what I like to refer to as a programmed cycle. Now, I want to be really clear, that's not standard terminology, and for a lot of people, they just would refer to that as a conventional FET. My concern is that words are powerful, and we talked about how natural sounds better because the word natural.
Yeah.
And for the same thing, to say that it's conventional just kind of makes it sound a little dated. But what we're really trying to achieve in a frozen embryo transfer, the way I'm describing it, is to make it a programmed cycle so that we really are trying to create or recreate the ideal environment to put an embryo back. Right. And so what a programmed cycle means by my definition is that we're accurately establishing day 0 of the cycle. Typically, we're doing that by, artificially using a birth control pill the month before so that we could say exactly when day 0 is. And then based on that, we can program exactly when someone is going to be beginning estrogen, and also exactly when and how much they're going to begin progesterone. So that by doing this, we can try to recreate what we call the ideal window of implantation. And this is why I like to refer to this as a programmed cycle.
And you can control a lot more of the variables.
Exactly. And one of the things that we've learned since many more centers have been using a program cycle is there's even newer technology today that allows us to do detailed testing of the endometrium to determine whether or not we need to further customize a cycle towards any one woman's individual responses. like what I like to explain to patients is that our program cycle is kind of best described as a one size fits most. And what I mean by that is we found through doing more detailed analysis, and we could talk about this in a future episode if we want to talk about a personalized cycle, is we found that using our typical protocol, we're able to accurately recreate the window of implantation in about 85% of women, meaning that about 15% will fall outside of that typically predicted response. And that's why I like to refer to it as one size fits most. It's not perfect. And, you know, with today's technology, we have ways of even further trying to individualize that. But again, that's even more complicated and would require additional descriptions and discussions.
So there is a difference between the conventional FET and then even a more specific.
Yeah, and that's what's often being referred to today as personalized FET.
Personalized FET. So
Yeah,
they're not all personalized. Or
no, because like I said, a program cycle is kind of one size fits most. And in order to do a personalized cycle, what you really need to do is you need to put someone through a program cycle and you need to test and see whether or not they respond well to that. And there's some situations where that's indicated, but it's really much more testing and treatment than is necessary for the vast majority of people. But this, I think, really gets to the heart of a question that has long been asked by women. How do I know that it's not, you know, the endometrium or a problem with implantation as opposed to a problem with the embryo? And this is part of where the newer technology, as well as controlling the, you know, the variables through a program cycle, that we learn to even further deduce and diagnose some of these people that have some of these less common problems that in the past we used to just shrug our shoulders and say we didn't know what else we could do differently.
Yeah, I'm just thinking, you know, when I went through this myself, going through IVF, and we had our one embryo, right?
Yeah.
So it's like, I felt it was a program or protocol designed to optimize everything. You know, I know you weren't my first doctor, you were my second doctor. And so looking at the lining, looking at the embryo, and again, I didn't even know the quality or grade of the embryo. I just went all in, but I felt it was a very customized program, but in a sense, was it more of just like a conventional?
Well, and to be honest, and knowing what I know about your specific cycle, which is a lot, is that was the most current thing available at the time you went through treatment. What I'm talking about now with personalized FET has really only been mainstream for about the last year and a half.
Oh, that recent.
We've actually been using it for a little over 2 years. But we were we were amongst the very earliest centers that had access to this technology.
But
this is what I'm explaining to you, is that we continually are trying to learn and adapt and grow and expand the options and offer greater customization. And so without revealing anything that you're not comfortable releasing about your own history, this wasn't available when you were going through treatment.
Okay, that clears it up, because I mean, yeah, that was 5 years ago. And
and I appreciate your willingness to share that, just for clarifications for the listeners. But today, for instance, when I have a patient that only has one embryo, I frequently am offering them the options of considering a personalized FET protocol before we thaw that first embryo, just knowing they're not going to get a second shot. And again, I think that's a better subject left for other days.
Yeah, another day. Wow. Thank you for kind of explaining that. I didn't know how recent that was.
Well, it is very recent. Like I said, there are some centers that might still not even be offering a personalized FET protocol for people. But these are the terms that we're trying to use to help differentiate fresh cycle versus frozen. And then in the category of frozen, differentiating a natural cycle FET versus a program cycle versus a personalized cycle.
Oh my goodness. Well, we trust you as the specialist, all of you doctors who this is your work,
But part of what I think is also so important, Lisa, and this is why I so enjoy working with you, is that the science in our field is constantly evolving.
Mhm.
And what I always try to do is I view each interaction with each patient and couple as a partnership. I always say, here's what I recommend and here's why, but
Yeah.
here's a second option and a third option, and here's the advantages and disadvantages of each. And then I ask them how I can best serve them. And so
Mhm.
that's why I think it's so helpful that you're out there trying to help people feel empowered to know what's available
Yeah.
so that they could take active, participation in the choices made in their care as well, because it's constantly evolving.
Yeah. Thank you. And I love these
Absolutely.
chats with you. This was a great clinical conversation. And for anybody that has further questions, feel free to message me, and Dr. Greene's at enhancingfertility.com. You have a great blog there. And have you been posting there lately?
Not as much as I wish I could. It's just been
Yep.
a very busy year and
Yeah,
a
I get
very
it.
busy timing year, but I always intend to do more, and then time happens.
No,
So
it's fun. You have lots of great resources there. And I know you are wonderful about sharing our chats. And
absolutely.
yeah, for those who would like further discussion on support through IVF, I'm at ivfmanifestingamiracle.com. And stay tuned for another clinical conversation. Thanks, Dr. Greene.
Stay happy.
You too. Bye-bye.